Thank you. Good morning. My name is Young Jung from Young Jung University in Korea. Thanks for giving me a chance to be here. For today, I'd like to talk about our experiences with the unilateral MRgFUS ultrasound pallidotomy in patients with Parkinson's disease. Okay. In Parkinson's disease, clinical interest of surgical treatments has shifted away from the lesion procedure toward the brain stimulation. However, MRgFUS has reestablished the beneficial effects of lesioning procedure these days. Thanks to its advantage of accuracy and safety, it has been used to treat several neurological disorders, including movement disorders. Especially in Parkinson's disease, beyond thalamotomy and subthalamotomy have been done successfully. And in this study, we tried to perform MRgFUS pallidotomy in patients with Parkinson's disease, particularly in regards to whether it could be feasibly done it could be feasibly used to make a lesion, a solid and effective lesion in the globus pallidus. The detail of this study is available now on the websites in the Journal of Neurosurgery. This study includes 10 patients with a medically refractory Parkinson's disease, and their main symptom was the levodopa-induced dyskinesia. And among them, 2 patients were dropped out due to insufficient temperature rise and the visual lesion in temperature map. And we performed unilateral pallidotomy using MRgFUS, and our target was the posterior ventral portion at the left globus pallidus interna. According to 1-year follow-up schedule, we serially evaluated clinical outcomes, including motor scales like UPDRS or United Dyskinesia Rating Scale, and brain images, and neuropsychological batteries, and quality of life questionnaire. This table is the information of sonication used in each patient, and patient 2 and 10 dropped out. In terms of motor functions, UPDRS Part 3 showed a decreased score in both medication on and off scores compared to baseline, and dyskinesia also improved by almost to 45% at the last follow-up. Although we didn't mention in the published paper, but we interestingly found that 4 of the 8 patients experienced a high temperature rise above 58 Celsius, and those lesions could facilitate better clinical outcomes than those with in the other 4 patients with a relatively low temperature rise. This is not statistically significant, possibly due to the small number of cases, but we think this indicates possible relationship between the temperature rise by the focused ultrasound and the symptomatic improvement. So these issues can be analyzed later with accumulating some more clinical data. We also identified a morphological pattern on MRI changed with the time. And in neuropsychological aspects, there was no significant changes among most factors, with the exception 2 subdomains, but the decline in these domains were frequently encountered in the advanced stage of Parkinson's disease, so we could not be sure whether this would be caused by the pallidotomy or Parkinson's disease itself. Despite the neurocognitive changes, but quality of life improved slightly better after the procedure. In most cases, there are some minor side effects like a headache and back pain, but only 1 patient, a 66-year-old man, suddenly experienced dysarthria and right hemiparesis during the translocation. An MRI demonstrated abnormal high signal change on the anterior and medial thalamus and internal capsule. We presumed it to be the result of some kind of a heating injury, and fortunately, he recovered completely within the 2 days and achieved improvement in dyskinesia. Our results in this study were comparable to the successful rates of the existing treatment modalities, but as I mentioned, that appropriate listening with a sufficient temperature rise by the sufficient energy delivery seems to be important in these issues. So at this point, how to increase the transcranial energy delivery is one of the main issues. So in our group already suggested that the skull density ratio over the 0.45 and less skull volume were significant factors for improving ultrasonic penetration. But despite applying more stricter standards of SDR to this study, but we failed to make lesions in 2 patients. So we think there might be another factors to influence our energy distribution, such as the heterogeneity of skull composition or incidence of angle to the skull, or other obstacles related to soft tissues around the head. So further basic researches are needed to overcome these limitations. In summary, this is the first clinical trial involving MRgFUS pallidotomy, and we demonstrated that clinical visibility of creating lesions at pallido targets. But we also recognize that there are still some limitation issues, so further clinical and basic researches are needed to expand the clinical indications in neurosurgery. Thank you for your attention. Yeah.
Thank you. There is time for at least one quick question, but I want to just remind everyone that at the end of this session, there's a discussion period. So again, we'll allow all the speakers to participate in that, and there'll be time for questions at that time. So are there any questions at this point? Well, thank you.